Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about seborrheic dermatitis. Definition: Seborrheic dermatitis is a chronic superficial inflammatory process affecting the hairy regions of the body, especially the scalp, eyebrows, and face. Its cause is thought to be an inflammatory reaction to the Malassezia yeast, formerly Psoriasis oval. Dandruff is scaling of the scalp without inflammation. Seborrheic dermatitis, a pink, slightly scaling patches. In epidermis, hyperkeratosis is present, and in dermis, perivascular inflammation can be seen. Incidence: Seborrheic dermatitis is a common problem affecting 3 to 5% of the healthy population and may be higher in African Americans, although it is thought to be an underreported condition and true incidence is likely much higher. History: The occurrence of seborrheic dermatitis parallels the increased sebaceous gland activity occurring in infancy and after puberty. It has a waxing and waning course with a variable amount of pruritus. It has been associated with Parkinson's disease and AIDS, especially when it comes on abruptly. Approximately one-third of patients with AIDS and AIDS-related complex have seborrheic dermatitis. In black patients, especially in the United States, seborrheic dermatitis is often normalized because it is so common. Physical examination: Seborrheic dermatitis has a predilection for the hairy regions of the skin where sebaceous glands are numerous. These regions are the scalp, eyebrows, eyelids, nasolabial creases, ears, chest, intertriginous areas, axillary, groin, buttocks, and inframammary folds. The rash is bilateral and symmetrically distributed. In its mildest form, dandruff, one sees fine white scale without erythema. The patches and plaques of seborrheic dermatitis are characterized by indistinct margins, mild to moderate erythema, and yellowish greasy scaling. It is uncommon for hair loss to result from seborrheic dermatitis. However, it can happen more frequently in the black community due to various hair styling and washing practices. This photo is showing the distribution area of seborrheic dermatitis. The distribution area of seborrheic dermatitis includes the scalp, eyebrows, eyelids, nasolabial creases, ears, chest, intertriginous areas, axillary, groin, buttocks, and inframammary folds. Differential diagnosis: The differential diagnosis of seborrheic dermatitis includes atopic dermatitis, psoriasis, tinea capitis, Langerhans cell histiocytosis, lupus erythematosus, rosacea, and perioral dermatitis. The distinction between seborrheic dermatitis and atopic dermatitis in infancy is often difficult, so many clinicians use the term infantile eczema when the dermatitis involves solely the diaper area and axilla. A diagnosis of seborrheic dermatitis is favored. Lesions on the forearms and shins favor the diagnosis of atopic dermatitis. Psoriasis may also enter into their differential diagnosis. Psoriasis limited to the scalp may be impossible to differentiate from seborrheic dermatitis. Involvement of nails, knees, and elbows favors the diagnosis of psoriasis. Tinea capitis should be considered in the differential diagnosis of seborrheic dermatitis, especially when the usual anti-seborrheic agents have failed, when the patient has hair loss, and when the patient is black and living in an underserved area. Otitis externa is not usually caused by a fungal infection, but rather is a manifestation of seborrheic dermatitis. Langerhans cell histiocytosis, an uncommon Langerhans cell neoplasm, may appear as a seborrheic dermatitis-like eruption. The occurrence of petechia and the failure of Standard therapy should make one suspect this is a cancer and obtain a skin biopsy. Facial involvement with seborrheic dermatitis may mimic lupus erythematosus or rosacea. Lupus erythematosus lacks yellowish, greasy scales and generally does not involve the eyebrows as does seborrheic dermatitis. If in doubt, the history, physical examination, laboratory tests, and skin biopsy will rule out lupus. Rosacea has inflammatory papules and pustules not seen in seborrheic dermatitis. Perioral dermatitis is a hybrid of acneiform papules and pustules plus eczematous patches surrounding the mouth and nares. When the dermatitis predominates, topical steroids are often prescribed, which cause steroid addiction to suppress the acneiform eruption that will flare badly when the steroid is discontinued. The conclusion of differential diagnosis of seborrheic dermatitis include atopic dermatitis, psoriasis, tinea capitis, Langerhans cell histiocytosis, rosacea, perioral dermatitis, and lupus erythematosus. Note, seborrheic dermatitis is the most common cause of a butterfly rash. Laboratory and biopsy. Seborrheic dermatitis is usually not examined by biopsy unless concern exists about the possibility of another disease such as Langerhans cell histiocytosis. The histopathologic change in seborrheic dermatitis are those of dermatitis and therefore are non-diagnostic with reference to other eczematous conditions. Therapy. Non-prescription anti-seborrheic shampoos containing zinc, pyrithione, selenium sulfide, or ketoconazole are the mainstay of treatment. The shampoo must be rubbed into the scalp and be allowed to sit for 3 to 5 minutes before rinsing, followed by the patient's normal washing routine. Patients with inflammatory seborrheic dermatitis that has not responded to shampoos benefit from a topical steroid in a vehicle of the patient's choice. High-potency steroids should be used sparingly, particularly on the face. Tacrolimus 8 ointment 0.1% or pimecrolimus 1% cream can be used as steroid-sparing agents. Note, high-potency topical steroids should be avoided in prolonged treatment of seborrheic dermatitis, especially on the face and intertriginous skin. The conclusion of therapy for seborrheic dermatitis. Initial therapy includes shampoos 1, 2, or 3 times per week to start, then once every 2 to 4 weeks for maintenance. Zinc pyrithione 1%, selenium sulfide 1% or 2.5%, ketoconazole 1% or 2%, hydrocortisone cream 1% or 2.5% BID as needed. Alternative therapy include tacrolimus ointment 0.1% or pimecrolimus cream. Course and complications. In infants, seborrheic dermatitis can be expected to remit after 6 to 8 months. In adults, the course is chronic and unpredictable. However, it is usually easily controlled with shampoos and topical hydrocortisone preparations. Rarely, it can cause widespread exfoliative dermatitis. In infants, the association of a seborrhea-like dermatitis with failure to thrive and diarrhea is called linear disease. Pathogenesis. The pathogenesis of seborrheic dermatitis is thought to be an inflammatory reaction to the resident skin Malassezia yeast. This lipophilic yeast is normally found on the seborrheic regions of skin, and proliferation is believed to play a role in this disease. The most effective anti-seborrheic shampoos have antifungal activity against these yeast organisms. Clinical case. A 34-year-old man presents with chronic flaking and redness of the scalp and face that worsens during winter and periods of stress. He complains of mild itching. On examination, there are erythematous patches with greasy yellowish scales on the scalp, eyebrows, nasolabial folds, and behind the ears. There is no hair loss. He is otherwise healthy. Which of the following is the most likely diagnosis? A. Psoriasis vulgaris. B. Seborrheic dermatitis. C. Tinea capitis. D. Contact dermatitis. And E. Rosacea. According to our explanations, the correct answer is B, or seborrheic dermatitis. Explanation. Seborrheic dermatitis is a chronic inflammatory skin disorder associated with Malassezia yeast. Commonly affects seborrheic areas like scalp, face, including eyebrows, nasolabial folds, ears, and chest. Characteristic findings include erythematous patches with greasy yellow scales and mild pruritus. It's more common in infants, which is called cradle cap, and adults, and may be severe in HIV or Parkinson disease. Differential diagnosis. Psoriasis is thicker plaques, silver scale often extends beyond hairline, also called corona psoriatica. Tinea capitis, patchy alopecia, broken hairs, usually in children. Contact dermatitis, history of allergen exposure, intense itching and vesicles. Rosacea, erythema with papules, and telangiectasia, no scaling. Okay, this was an explanation about seborrheic dermatitis. Thank you for your attention.